thank you so much, everybody, for signing on. First, I would like to thank Dr. Matos and the Pan American Trauma Society for the opportunity to present here today at our weekly grand rounds. I would like to thank Gary up front for the technical support and setting everything up, as well as Valeria, who did a lot of work with helping us with setting up the questions and everything. We have a wonderful audience here today from pretty much all over the world. We have Dr. Rizzoli from Qatar. We have several physicians from Brazil, Argentina, Italy, Milan, from the Caribbean, from St. Lucia, and several places from the US as well. So it's a great audience. And what we do today, typically, as you know, we usually discuss one major case and have interactive discussion throughout the case about the management of one case. Today is going to be a little bit different because this is not going to be a trauma case. This is going to be 3 very straightforward acute care surgery cases, general surgery cases we all take care of every day, but in the context of the COVID pandemic. And the discussion really is going to be on, how does that change on what we do every day? How does it change how we treat those general surgery patients? Or should it change, or should it not change? So we're going to go through those 3 cases. We're going to have interactive questionnaires for the audience throughout the presentation. And at certain times, Valeria will start up the questions, and you will be able to click on your screen there in a multiple choice format. So you'll be able to click and send in your response. And then we'll show you at the end of each block of this questionnaire what the audience is thinking. And we will have an open mic discussion at the end of the presentation. We have about 20 minutes at the end of this hour to discuss the management of those cases, hear different opinions from the audience. And so I would like to ask you to wait for the open discussion until I presented all the 3 cases, so we don't run out of time in the middle of the presentation. Okay, so that's a little bit different today than what we normally do. Okay, let's see. Can you see the slides?
Yes.
Yes, sir.
Okay, very good. Yes. Disclose.
Yes.
First of all, as you all know, SARS-CoV-2 virus has affected more than 2.9 million people as of now. Unfortunately, we lost over 200,000 patients worldwide. In the United States, where I'm currently practicing, we have over 900,000 confirmed positive tested now. As you all know, it's a global pandemic, so all continents are involved. The 2 main epicenters are pretty much Europe and North America right now, United States, but several other cities still around the world have a significant prevalence of the COVID-19 disease. This map shows the United States a few days ago. You can see it initially started in Seattle on the West Coast, and shortly thereafter also major outbreaks along the East Coast. It appears that the virus strain at the East Coast is coming from Europe, whereas the West Coast in Seattle it was more directly from Asia. You can see how it spread throughout down the East Coast, and then towards also more towards the rural area in the United States now. You can see that Florida itself, down in Miami, where I'm presenting from right now, has also significant disease burden. This is a map from Florida a few days ago, and you can see that the region around Miami, Miami-Dade County, and Broward has significant prevalence of disease. Florida, as of now, has over 30,000 confirmed cases, over 1,000 deaths, and Miami-Dade County, our area, has confirmed 10,000 cases, and the death rate is a little bit over 280 as of now. Broward, just north of us, has also significant prevalence of disease. Those are basically the high population centers of Florida down here. As you can see on this distribution for Florida, we just peaked about a week ago. We have a slow downward trends now throughout the last week of cases and new admissions to the hospital are slowly downwards trending. Now, there were a couple of interesting studies come out over the last couple of days looking at IgM, IgG testing and disease prevalence in our communities. And one study from New York suggested that up to 21% of the population of New York City had contact with the virus. A large amount, over 50%, completely asymptomatic, which makes it difficult for us to detect those patients unless they're tested. A similar study done in Miami-Dade last week showed that about 6% of the population has antibodies against coronavirus, COVID-19. If we calculate that onto the entire population of Miami, if those numbers are correct, it would mean that approximately 165,000 people in our city had contact at some point with the virus, meaning they either went through the disease or still active virus carriers. Again, more than 50% were completely asymptomatic when screened for any symptoms. So what does that mean for us? And does that mean when we have such a high prevalence in our community that we have to change the way how we practice general surgery, acute care surgery? And we're not talking about the elective cases in most areas where we have higher disease prevalence. As you know, we stopped doing all kind of elective surgeries in order to refocus our resources, our ICU beds, our personnel and so on to treat those COVID patients. So we're focusing really on the acute care surgery patients who continue to come to our emergency rooms and we have to take care of them. So Valeria, can you launch the first survey question to the audience? Block 1. Very good. So the first question we just want to ask you very quick, you know, the area where you're practicing, we grouped it by continents because we have so many different countries where we wouldn't fit it into the survey question. So it's just click on where you're currently practicing. And then when you keep scrolling downwards, you will see the next question. So question 2 is how many COVID-19 patients are currently admitted to your hospital? So just so we have an idea for the audience when we show you the results, you know, what the disease prevalence is in your region. You know, so you can see there, you know, option A is less than 21, then B is 21 to 40 and so on. If you don't know the number, then you can have the option to click unknown. Question number 3 would be how many patients with trauma have you seen at your hospital who turn out to be COVID positive when you tested them? So how many COVID-19 trauma patients you have been taking care of? I would group both. There's one question missing, so maybe we can put both together. How many trauma patients and acute care surgery patients you have been taken care of? Let's put both together because we had 2 separate questions, but one is missing there. So combine any surgical patient you were involved taking care of who had COVID-19. And then question number 4 is a little bit different. This is a question to ask you, how many patients you took care of with a surgical problem, trauma or acute care surgery at the time did not have a positive COVID status, but later on tested positive. So we're trying to look here basically at exposure. So see if you had any patients who turned up positive. But by the time you provided care for them, were not positive. Okay, Valeria, whenever you think you have enough respondents, you can close it up.
We are about 58%.
Yeah.
Maybe one more minute.
I see some people still clicking, so.
Yeah.
Yeah, Dr. Pust, some people are not physicians and they're only observing, so.
Okay. All right, so Valeria, if there's no significant change, you go ahead and close it up. Okay, so you can see, very interesting, about 1/3 of the audience is currently practicing in North America. We have several physicians on from the Caribbean, a good quarter from South America. And So when we scroll down here, we scroll down to question 2, you can see that significant amount of the largest amount of hospitals has less than 21 patients now. And then you can also see that 1/3 of hospital has more than 80. So either you hit pretty hard, so you have a lot of patients, or you're in a hospital which has a smaller group of patients, but pretty much significant involvement of admissions to the hospitals here. And now the third question is very interesting. So this is a question like, how many patients have you been taken care of who had COVID? So half of the audience did not have any surgical patients yet with COVID. That will very well change over time once the pandemic progresses. But a good half of you have been involved in care of surgical patients who ended up testing positive. So that's very interesting. And you can see on question 4 that a significant amount of patients you took care of were not positive by the time you took care of, but then subsequently tested positive. So that's a very important number, because it shows you that those patients presumptively had no symptoms and were asymptomatic carriers. You happen to see them for a surgical problem, and then subsequently on screening testing, they turn up positive. And that's the issue we're seeing here a lot in Miami, and I want to show you in our presentation. Okay, so very good. So let's move on and start the first case. So the first example is a 22-year-old Hispanic healthy female. She presented to our hospital in Miami with progressively worsening bilateral lower quadrant abdominal pain for the last 24 hours. She had no other associated symptoms. Her vital signs were normal. She had normal oxygen saturation, no fever, no other complaints. Physical examination demonstrated tenderness in the right lower quadrant. She did not have any obvious peritoneal signs. She did have leukocytosis, and she had a CT scan done by the emergency room, which you can see here, that there's a prominent enlarged fluid-filled appendix. There might be an appendicular leaf at the base of the appendix. On the next cut, you can see that there's some fat stranding behind the appendix in the retroperitoneal space, suggesting of inflammation around the area of the appendix. And then again here on the third cut, large enlarged appendix, which appears to be consistent with her clinical examination and her imaging finding and her history that this patient has acute appendicitis. When you look at the next window, when you pay attention to the lung window, you can see that incidentally we see on the lung window some small kind of glass ground, small infiltrates where you see the yellow arrow. And on the next slide, you can see a similar lesion on the right side, so it's bilateral. And on the transverse cuts, you can see again multiple foci of inflammation there. So this patient came fairly early on during the pandemic to our hospital. And once we saw those lesions in the lung, we were suspicious why she has those, right? She shouldn't have those. So the official reading for the CT scan was acute appendicitis and then multiple ground glass opacities and bilateral lung fields. So that triggered a discussion here and see how we should treat this patient. So let's ask the next question, Valeria, if you can open the questionnaire. So this patient comes basically to you. You would see this patient now in your emergency room with those findings. And my question is for the audience, how would you personally treat this patient? Would you go ahead and proceed and do a standard laparoscopic appendectomy at this time? Would you take her for an open appendectomy and avoid laparoscopic surgery? Would you go ahead and admit her to first surgery for now, get a COVID-19 nasopharyngeal swab test, which by that time at our hospital took about 1 to 2 days to come back. Now we get it on the same day, but different institutions have different turnaround times. So you know what the turnaround time is maybe for your institution. So would you wait and do not surgery and wait and see what her test results show? Or would you just treat her with antibiotics at this point and not doing any surgery at all, and then probably plus minus testing? So please go ahead and click your choice. And if you have no opinion, you can click option 5.
Just be sure everybody after clicking, click submit at the end, okay? So need to click, put your choice and click submit at the end in order to your answer to be computed, okay? To be validated.
Very good. Hello, Tony. Thanks. Thanks for the reminding. Okay, go ahead, Valeria. Okay, so that's interesting. So about half the audience would proceed with surgery at this time, and a small percentage of the audience would choose to admit the patient and wait and see what happens to her COVID status based on those findings on the CT scan. The interesting thing is that she has no clinical symptoms of COVID disease, no fever, no respiratory issues, no cough, no nothing. You just saw those little spots on the CT scan. Okay, so we went ahead and we decided to admit the patient and do testing, and her test came back positive. So she tested positive for COVID-19. And with that knowledge, now you basically a day in, she is at the hospital now for 24 hours. You know she's positive. How would you proceed? Valeria, can you open the questionnaire again, please? You have three options, basically. You can say, okay, we are not going to operate on this patient. I don't see a reason to operate on her while she has tested positive for the virus. Maybe there's an increased risk for the patient. There certainly is an increased risk for the providers performing the operation. We have to put on a general anesthesia, and which you know, is an aerolizing procedure. Or do you say we're going ahead and we're going to do a laparoscopic appendectomy using the PPEs and so on? Or do you avoid laparoscopic surgery at this time and perform just an open appendectomy? So
but then, how is the patient doing clinically?
Clinically, it's the same. She has mild tenderness in the right lower quadrant. She is, you know, other than that, doing fine. Focal disease, no peritonitis, not septic. So again, you have here the options. And don't forget to click submit at the bottom of the window. All right. Okay, Valeria, go ahead. Okay, so that's very interesting. So we see there's a change now. People decided, well, no, we know that she has COVID, that about almost half the audience, 40%, decided not to do any surgery right now, defer and treat her with antibiotic therapy. So we see here that basically the COVID status on this patient changes, right? Everybody in normal times, no COVID, probably everybody would have taken her to the OR for appendectomy. So it significantly changed. 20% still decide to go ahead and do laparoscopic appendectomy on her. And 1/3 would decide not to do laparoscopic surgery. And we'll talk about it at the end more. Should we do laparoscopic surgery or not? That's one of the main discussion points here. So 1/3 of you decided to do open surgery. Very good. Let me see if we can move ahead. So we decided at our institution also to do non-operative management. She was admitted to a COVID unit, regular floor, not ICU. She was done on antibiotics. She improved fairly quick, was advanced, we advanced her diet, and then subsequently she was discharged home with no surgical interventions, only antibiotics, and she was placed in self-quarantine at home and did well. At this point, I want to show you very quick this study from Lee from Wuhan, China. They had 34 patients who underwent elective surgery. Now, most of those were fairly large operations with laparotomies and so on, not, you know, minor appendectomy operations, large operations. But that was also early on in their pandemic and in their disease process. So at that time, they did not know that those patients were COVID positive. They subsequently tested positive. And a significant amount of those patients actually became very sick and required ICU admission. You can see here that 44% of patients who had an elective operation and tested positive for COVID ended up in the ICU with a very high mortality of 20%. So the additional stress of general anesthesia and surgery during the time of a COVID infection had significantly worsening outcome if you compare to COVID patients to the general COVID population. So we have to be careful to do surgeries on patients who are COVID positive. So just a quick reminder, there have been multiple randomized controlled trials looking at antibiotic therapy for appendicitis versus surgery. One was the APEC trial done in Finland a few years ago. It was a multi-center study published in JAMA. They enrolled 530 patients with uncomplicated acute appendicitis confirmed by imaging. And basically there was no difference. Antibiotics were not inferior to surgery. The second study was the NOTA trial, which was published in the Annals of Surgery in 2014. A smaller group of patients, 159 patients enrolled, treated non-operatively with antibiotic therapy. And they had a failure rate of about 12%. Those within the first week, those patients then subsequently required surgery. And the 2-year recurrence rate was 13%. Okay, out of all failures, 14 out of 22 patients were still successfully treated with a second course of antibiotics. And then the third trial is a British trial, 369 patient randomized to antibiotic therapy versus surgery. And you can see similar results here. Failure rate of recurrent appendicitis about 14% within 1 year. Minor complications were similar. Major complications were actually higher in the operative group in that trial, mainly abscess formation. So they concluded that antibiotic treatment appears to be safe as first-line treatment for appendicitis. So we will discuss this at the end of this presentation, but I think there's some data suggesting that maybe the right thing to do in a pandemic is to do non-operative management of appendicitis. It's probably controversial. We'll see what you guys think at the end. The second case, we'll go a little bit quicker, is a 57-year-old male who has a history of heart failure with a low ejection fraction. He has a history of a cardiac thrombus and therefore is on Coumadin. He also has a history of polysubstance abuse and hypertension. So he showed up in our emergency room with 4 days of bright red blood per rectum. He has no prior surgical history, no prior colonoscopies. He was tachycardic. He was actually hypotensive. He had abdominal discomfort, but no peritoneal signs. And he had a significant metabolic acidosis. He was very anemic and he was cholopathic with an iron of 7. He had an associated lactic acidosis. He was had impaired renal function with an elevated creatinine. However, his white blood cell counts were normal, troponins were normal too. Due to his abdominal pain, he had a CT scan ordered by the ER physicians, which showed this. It showed an intersusception of the ileum into the cecum. And on the frontal cuts, you can see as well that there's about 20 to 30 centimeters of ileum intersuscepted into the cecum with significant associated wall thickening of the cecum. It's a little bit hard to see because it's a non-contrast study, but we put the yellow arrows there to kind of point it out. So the official diagnosis on CT scan by the radiologist was ileocolic intersusception. So our plan was to admit the patient to our surgical intensive care unit, transfuse him with packed red blood cells, and correct the coagulopathy with fresh frozen plasma, as well as careful fluid resuscitation to correct the acidosis. And we also plan to do a cardiac echo to see what his cardiac function is. And with the plan that most likely this patient may require surgical intervention. And at that time, we started to do a screening of all patients who require surgery or any invasive procedure in our hospital, which was about 2 weeks ago. And he actually got better. He responded well to the resuscitation efforts, and his acidosis resolved, his hypertension resolved, and also his abdominal pain pretty much improved. So interestingly, when we sent the COVID-19 study, it came back positive. So it's again a patient who came with a different surgical problem, has no COVID symptoms, but on screening was found to be carrier of the virus, which was a problem again because this patient was admitted to our surgery intensive care unit, not to a COVID intensive care unit, which resided of exposure to other patients and to staff. From that day on, we actually changed our policy. All patients who get admitted to our intensive care unit, we're placing a face mask on the patient as well. And we're screening now all patients who are getting admitted to the hospital this time. But at that time, our testing capacity was still very limited. So we're only screening for patients who require surgery. But we were surprised at that time that this patient is positive as well. So now the question to the audience comes, how would you manage this patient? Okay, so Valeria, can you open the questionnaire again, please? Question 7. Block 3, yeah. So option A, in the absence of peritonitis, acidosis, or obstruction. So we resuscitate the patient, he got better, the acidosis is gone, he has no obstructive symptoms, and he does not have peritonitis. Would you defer operative intervention at this time and wait until his COVID disease is resolved? Or would you go ahead, option B, and take the patient to the operating room from a laparoscopic right hemicolectomy with full PPE and aerosolization precautions? And if available at your institution, you can do this even in a negative pressure operating room. Or would you say, I'm not going to do laparoscopic surgery at the times of COVID due to risk of aerosolization and higher viral exposure, and I'm going to do an open operation? Or do you feel, you know, this is a patient who has a lot of medical problems, we're in the midst of a pandemic, and maybe comfort care is the right for this patient because there may be a high likelihood that he may have an underlying malignancy, and take up significant resources at your hospital because most likely he will be on mechanical ventilation and so on. So hospice care is an option. And then last option is I have no opinion. So please go ahead and click. And then there's a second question in this block. If the patient now deteriorates, so if you choose not to operate initially and the patient deteriorates, meaning he develops peritonitis or he progresses with intestinal obstruction or he gets acidosis and you're basically forced to operate on him, how would you do it at that time? Would you do it laparoscopically? Would you do it open? Or do you feel like, you know, if this patient develops peritonitis and deteriorates further, maybe we should offer him comfort care measures in hospice? And Valeria, whenever you...
So the first patient is stable, second patient starts to deteriorate a little bit, right? Has some complication, correct?
Correct. That's
for everybody to understand, yeah.
The first question 1 is basically patient responded well to resuscitation and is now more or less asymptomatic, and you observe him. And the second scenario is like this patient basically is deteriorating on you and he forces you to operate. Would you go ahead and operate, or would you do hospice care? And if you do operate, what approach would you choose, laparoscopic or open? Okay, so the majority of the surgeons in the audience decided to observe this patient, 58%. 16%, still a significant number, would go ahead and do it open. I think it's very reasonable to do an open approach, especially since this patient also has a lot of comorbidities and a poor cardiac function. And laparoscopic was also performed. We'll ask the audience later on. Somebody clicked other, so we'll see what the alternative option is here. And then the second options, all of you would progress and say open surgery. So that's very interesting. Very small number what did laparoscopic surgery. We will discuss it in a few minutes. And I'm also curious about that somebody decided to do hospice care. So we'll discuss that as well. Okay, let me close this. So we also decided at that point, since the patient improved with resuscitation, to not operate on him and to basically wait until his COVID status is resolved, until he has no further disease. And at that point, you know, if he continues to be asymptomatic, we probably should have a colonoscopy first to make a diagnosis to see what's the cause of the underlying intussusception here. Probably a high likelihood of malignancy, but maybe the patient has just lymphadenitis from COVID, and the lead point is lymphadenopathy causing this intussusception, and nothing else is going on there. And maybe he resolves spontaneously, so probably another imaging study is also to consider here. So our findings, we basically remain asymptomatic, and we're waiting for his COVID status to resolve. And now the last case is very straightforward. It's a 26-year-old, or you would think is straightforward. It's a 26-year-old male who is a known type 1 diabetic. And he presents to your emergency room. He came to us about 10 days ago with worsening right lower extremity pain, difficulties to ambulate, to walk on the leg actually. And he also complained of extreme fatigue and generalized body pain. He was tachycardic, and on clinical examination, he had significant swelling and tenderness in the right thigh. Laboratory workup demonstrated that he had severe ketoacidosis. He was very acidotic with a pH of 7.0 and positive ketone bodies. He was profoundly hyperglycemic. His glucose levels were like in the 600s. He was hypokalemic, and he had a significant leukocytosis. Because he had this pain in the right lower extremity, he underwent a computer tomography of the leg, where you can see that he has a deep subfascial abscess all the way down to the femur bone. Notice also that in the subcutaneous tissue plane, you do not see any inflammation. So he does not have any cellulitis. Externally, the leg looks completely normal, just a little bit of swelling. And you can see there that there's a significant abscess with some septations. And on the frontal reconstruction, you can see again the abscess deep between the muscle groups down all the way to the femur bone, and a very clean subcutaneous tissue level. So no cellulitis there. The patient did deny he's not injecting insulin into this leg. He's not doing any injections there. So there was a spontaneous kind of myositis turning into an abscess kind of process in this thigh. So the patient was admitted to our surgical intensive care unit. We did fluid resuscitation. He was started on an insulin drip to treat his ketoacidosis. He was started on antibiotics to treat the underlying sepsis. And in anticipation of interventions, we did a screening COVID test. And again, this patient turned back positive. So that's the third patient we had in a time period of literally 10 days who came with a surgical problem to the hospital, who happens to be asymptomatic carrier of the disease. So, you know, this is a group of patients we identify. We have to be very carefully, because it's, you know, if a patient comes with COVID symptoms, you know, we are alerted, we know they may have COVID, they get admitted to the COVID route unit and so on, and we're doing the full PPE and everything, but those patients keep tricking us, right? So this patient was also admitted to our surgical intensive care unit, a non-COVID area, and basically with the risk of exposing other patients and healthcare worker staff. At that time, we had already changed our policy. You know, all the nurses and medical staff in our intensive care units wearing N95s around the clock by that time, and eye protection and so on. So the exposure to the staff was not really there, but you know, we really noticed that there's more and more patients coming who are asymptomatic carrier of the virus, who show up to our institution with surgical problems. So one more audience session here. Valeria, can you bring up question 10, please? So the question is, how would you treat this patient if you have this patient now? He's septic from the abscess. He's significantly sick. So the question is, what are we going to do with him? Would you only treat antibiotics and not do any surgical interventions? Would you do antibiotic treatment only until his COVID status is resolved, and once he is COVID negative, drainage procedures? Or would you take him to the operating room now after he is resuscitated from his ketoacidosis, and then go ahead and drain him in the operating room, open drainage with full PPE and aerosolization precautions? Or would you opt for interventional radiology drain placement and consult your interventional radiologist to drain this abscess? Those are the options. And then the second question is, if you do decide to take the patient to the operating room, how would you drain this abscess? Would you just use scalpel and avoid electrocautery? Since we know that electrocautery creates significant aerolization potentially of the virus, or would you use electrocautery anyway and trust your PPEs? And then the third question on the survey block is, how would you manage the wound? Would you put a pen restraint? Would you do conventional packing and change the packing every day? Or would you put a vac dressing on? The reason why we put this question is kind of, we always think about to minimize interactions with COVID positive patients, you know, to avoid unnecessary exposure of the healthcare providers and also to avoid to unnecessary burn through PPEs, which are obviously very limited. So here's really the thing, you know, maybe we should do something different than we normally do in order not to have to deal with this wound every day. Okay. All right, Valeria. Okay, so here are the results. Okay, so it's almost split. So a little bit majority, 41% decided to do interventional neurology drain placement. I think it's very reasonable. At our institutions, we're getting a lot of pushback from the IR people when even patients are just in a rule out. You know, a lot of people don't want to deal with or take the risk. So it's not that easy for us to get IR drainage, but you can try and fight for it. And then the other option is 30% of you decided to take the patient to the operating room. And about, I can see, oh here, 14% decided to do antibiotics and defer to drain this abscess until his COVID status is resolved. So we discussed that in a minute. I think those are all good options. Nobody is using electrocautery. I'm very happy about it. Everybody's cutting good old fashioned with a scalpel. And then how we manage this thing. So it's interesting. So half of you decided to place a vac dressing, probably because it's a somewhat appears to be a closed system, and maybe it minimizes, we don't have to do a dressing change every day, but it's still fairly fresh, clean, fresh abscess cavity, so it's pus and everything. So putting a vac on, we discuss it too. Packing is gauze packing 23%. The downside of that is obviously that, you know, we have to do this every day. And then minority decided to do a pen restraint placement. So what we did on this patient, we also decided to take him to the operating room, mainly because we felt it was a very low velated abscess, and probably IR drainage will not clean this out, you know, sufficiently and fast enough. And so we decided to take the patient to the operating room. You can see here our COVID transport team transporting the patients from the COVID unit to our dedicated negative pressure operating room we have here at our trauma center. You see that they're wearing full PPE. Our hospital has basically created those PPE kits where you get basically in one plastic bag the bunny suit, an N95 mask, surgical gloves, as well as a face shield and goggles. And those get centrally distributed so that the hospital has control over the PPEs and we're not burning, you know, too fast through our PPEs. So those sets get handed out for surgical interventions and for aerolizing procedures. Here you can see the anesthesia team intubating the patient. They're using a video laryngoscope to maintain distance between the patient's airway and oral cavity and the anesthesiologist. At this time, these two anesthesiologists decide also to place a striker head, you know, those full head cover to minimize droplet exposure to their faces, and then go ahead and intubate the patient, rapid sequence induction. This is the full PPE suit. You can see it's the bunny suit. We at this time still wearing shoe covers, 2 pairs of gloves, an N95 mask covered or protected by a surgical mask, and then the face shield for droplet precautions. Here, regular disinfection of the gloves, just as you would do if you go for surgery without the PPEs. And then replacing the sterile surgical gown and the sterile glove layer on top of that. You can see for this case, it was only the attending surgeon. We asked the resident and fellow to stay out of the room in order to minimize the amount of people who are getting exposed and also to minimize the usage of PPEs. Obviously, if you do larger procedures, laparotomy or so on, you may have to need the assistant. So we went through these questions. Before we open up for open discussion, we have about 20 minutes. I want to go very quick over those test charts here, because we always talk about, okay, we test the patient for COVID, and then if they're negative, we do elective surgery, or if they're negative, they come to the regular floor out of the COVID unit. So, but what does it really mean to test negative? Because the issue we're all facing is a very high false negative test rates, right? So if you look at this table here, which was published by Zhao in the Clinical Infectious Disease Journal just in end of March, you can see that in the first 7 days, the RNA PCR testing only correctly identifies patients as COVID positive in 67%. So it misses 1/3 of the patients who are virus carrier but test negative. And then those numbers drop further in week 2 and week 3 of the disease process. So in the second week, it's basically like flipping a coin, 50% only testing correctly positive. Since about 10 days, we have at our institution now IgG, IgM testing availabilities, still very limited in capacity, so we're not able to test everybody yet. But you can see that, you know, in the first week, obviously, as expected, the sensitivity is pretty low. But it then goes up towards the second and third week. And in the third week, you can see that IgM seems to be fairly sensitive with 94%. So my questions for the audience is, that's the last questionnaire. Can you go ahead, Valeria, and start it, please? What are you currently doing for testing to screen your patients prior for operative intervention? And that's mainly also like in the context of thinking about to restart elective surgery at some point. What do you think, what should be done? You know, should we do one RNA test, one PCR test enough? Should we do 2 PCR tests? Option C on the same day. Should they be spread apart over a certain time distance, like at this time 72 hours, 2 PCR tests at 72 hours? Or do you think we should combine them with the IgG, IgM test, option E and F? So option F is basically IgG, IgM and 2 separate PCR tests. So go ahead and choose. And then there's a couple more questions in this block, which is the last block. Question 2 is, in general, if you now, as of today, see a patient in your emergency room with acute cholecystitis and he's positive for COVID, how would you treat this patient as of now? Would you go ahead and just do antibiotics? Would you do laparoscopic cholecystectomy? Would you do an open course cholecystectomy, or would you place brain? And then question 3 is the same for appendicitis. We kind of had this earlier already, I guess. So most of you decided to just do antibiotics. And then question 4 is, we want to survey and see, if you do laparoscopic surgery, do you have the gas smoke evacuation filter system available at your institution to use for laparoscopic surgery? And the last question is, I promise it's the last question, is, do you have any written policies and procedure in place now at your institution to govern surgery in COVID positive patients or high suspicious patients? And then don't forget to click submit, please. Okay, Valeria, are we ready to show the results? Coming up. Okay, so you can see that the majority at this point, about 1/3 of you are doing what most institutions are doing, 1 PCR test. Now with increased availability of testing capacity, we start to retest more patients. We do 2 tests. The problem is, you really have to wait in between. So doing two tests at the same day is probably not going to change much. So we had several patients here who turned positive, you know, even after 2, 3, 4 tests subsequently turned positive. we see a trend now that more institutions starting to do IgG, IgM testing. So most of you think probably IgG, IgM plus one PCR test will be what's going to happen. Second question is, 2/3, so the overwhelming majority decides to treat acute cholecystitis at the times of COVID with non-operative management. That's interesting to see. And the last question, same, appendicitis, non-operative management, the vast majority. So we can see a trend here. The trend seems to be like in this common, straightforward acute care surgical diseases we see fairly often. If those patients happen to be COVID carriers, it changes how we manage them. And then I'm glad to see that 75% of you have actually the gas smoke evacuation filter system in place, and we'll talk about it right now, you know, how effective they really are. And a great majority of you implemented policies and procedures in your institution to kind of governing how you take care of those patients. So with that, I would like to open the discussion to the audience and talk about it a little bit more. Before we go there, a couple of resources. Again, most of you all know the American College of Surgeons has guidelines on surgery in COVID patients at their website at fax.org/COVID-19. Same for the care of trauma patients. The American Society for Surgery and Trauma has guidelines up on their website helping us to know how to deal with trauma patients who have COVID. And then 10 days ago, the NIH published the coronavirus treatment guidelines, which is a very excellent document, very, very structured, where you can quickly review what we should do with those patients. So with that, I would like to open the discussion. And maybe we start with Dr. Rizzoli in Qatar. What do you think? How should we change what we do in acute care surgery in the times of the COVID-19 pandemic?
So, thank you very much for the excellent presentation and for putting together the key directives today for COVID patients. My opinion is that I only realized recently that everyone will come in contact with the virus, that all the measures being taken worldwide are not to prevent us from becoming infected with the virus, but to reduce the number of people requiring hospital resources at once. So the goal of social isolation is not to prevent us from becoming COVID positive, but is to reduce the number of us that are going to be sick at the same time and require to go to the ICU at the same time. So the world will be a different world. We're all going to be positive, so we have to deal with this infection. We have to learn. I'll tell you, it hurts me to think that appendicitis can be treated with antibiotics. Despite the evidence, my brain is still wired to say that for appendicitis, a young woman, had you done surgery the day she came, by the time you got the result of the COVID, she would be home, right? And doing fine. So, but I agree completely with the point of view. Nowadays, the best management, and unless surgery is necessary, that you should actually go for the non-operative management of those common surgical diseases. I'll just say that the things, especially here in Qatar, looks like that every day there's a new rule, there's a new regulation, there's a new directive. And so just, we have to keep updated with meetings such as this one. So thank you very much for the presentation.
Very good. Dr. Kazim, what do you think? In the age of COVID, should we operate on this patient? Should we say, like, you know, we do the appendectomy, we do full PPE, and then get the patient home faster, get them out of the hospital? And we should be okay as a surgical team and the anesthesia team as long as we use the full PPEs.
Well, It is always a pleasure to attend your presentations. They are so informative and educational. And today is just about the best on COVID and how we should manage patients according to the experience that you have had in Miami. Okay, having said that, I think I agree with the doctor from Qatar. I think 99% of the population will be affected with COVID, out of which about 1% to 2% of the patient will succumb drastically to the COVID infection. So as surgeons, now I am beginning to think that every patient that comes through the ER will have COVID one way or the other. So you better get used to the idea of the different type of world that you will be treating. So having said that, let me comment on the two patients that you presented, the acute appendicitis and the cholecystitis. The acute appendicitis case, if you recall, had a ficolate. That goes against the grain of surgical thinking, in my opinion. Patients who have ficolate supposed to have an obstructive appendicitis, and hence it is not a simple appendicitis, and they should be dealt with surgically. That was my teaching, and that's what I was taught. So now you're telling me that you're going to treat that with antibiotic. It is change in paradigm. So that's the first thing. So does that mean every patient who comes in with ficolate, we're going to be treating with antibiotic and then suffer the consequences of that later on? I don't know. Second question, second case is the one that intrigued me quite a bit, cholecystitis. Yes, 90% of the patients who have cholecystitis can be treated with antibiotic, but we did not do that in the pre-COVID area. Most of the patients underwent surgery. So again, we are changing the paradigm. So we'll have to think about treating this patient in a different way than we are accustomed to. And I don't know what the consequences of that is going to be. Is the mortality is going to go up significantly as opposed to when we used to do elective or semi-elective cholecystectomy? Again, I don't know. Does COVID present additional problem to the patient with regards to recovery and complications? I don't know. So those are the things that I've been thinking of. Thank you.
Thank you, Dr. Kazim. Dr. Namayas, my boss. Could I operate on those?
You read my mind.
Could I operate on those patients? You're going to fire me for just treating them with antibiotics. What do you think?
No, I'm not going to fire you because I've personally started antibiotics on these patients that I normally would operate on and had worse outcomes, and I feel terrible about it. And I think what's going to happen is we're going to evolve, right? When the first day we started doing this, it was as if there was radioactivity in the air trying to kill all of us in real time. And as each day goes on, we're becoming more accustomed to the fact that, you know, when we're in a open air place without a lot of people, we don't have to N95. If we're doing a highly aerosolizing thing or we're in a unit full of COVID, we wear the N95. And it's going to be just like the older among us remember HIV. I mean, everyone was scared to death to operate on HIV, and then we slowly got used to it. Now we don't even think about it. And I think the same thing is going to be with COVID. We're going to learn how to protect our eyes, how to protect our mouth and nose. We're going to learn not to touch our face, and we're going to treat the patients just like we treat all the other patients. It's slowly changing already. I think. I feel like the attitudes are changing. People are calming down, and they shouldn't let their guard down, but you just have to wear the appropriate PPE, and I think we're changing. So I think that's what's going to happen. But yeah, it's you know, it's hard not operating on appendicitis.
Thank you. Next, I would like to ask to bring on Dr. Charlie Greenidge from St. Lucia, my dear friend. St. Lucia, just for the information of the audience, they're like several steps ahead of all of us. Because what they did is they have about 20 confirmed cases, and Charlie can talk about it more in the community. But St. Lucia has an older hospital, which was there for many years. And they just finished to build a new hospital a couple of years ago, which was not in use yet. They haven't moved into that hospital at that time. With COVID, that all changed. So the new hospital now is a non-COVID hospital for all the patients who come in with other medical problems. And they have a designated COVID hospital where they only see the COVID patients. So Charlie, I wanted to ask you, so what do you do now? Does it mean if a patient comes and he tests positive for COVID but needs an operation, you're going to do it in the old hospital? Or are you going to transfer, or you're at the new hospital and you find the patient with COVID, you're going to transfer him to the other? How does it work for you? And number one. And number two, would you do laparoscopic surgery? Do you feel like that the filter evacuation system is good enough? Or do you think it's still a significant risk for the staff to do this?
Okay, hello, Dan.
Yeah, we hear you good.
Oh, great. Thank you very much for inviting me to this really great meeting. It's wonderful to have the support of all your colleagues, especially now when you're worried about having low or no resources and you can hear what other people are doing. So St. Lucia, I have to say, I'm very proud, was able to mobilize the move to a new hospital. We've had a new hospital built and it's been there for 5 or 6 years and we've not been able to move into it for one reason or another. But because of the COVID situation, we basically moved almost overnight. So now we have a very comfortable situation where we have what we refer to as a COVID and non-COVID hospitals. So the old public hospital is now the respiratory COVID hospital. And basically what we are trying to do is to concentrate all our COVID positive work there. So technically, if someone has acute appendicitis and let's say they needed to have an operation, let's say they didn't respond to antibiotics and they had to have an operation, from the time we know that they're COVID positive, they will be transferred to the COVID hospital. And the new hospital, as well as 2 other hospitals on the island, are being used to manage non-COVID patients. You asked about the laparoscopy. Our laparoscopy setup is not highly sophisticated, and we don't have reliable viral filters for laparoscopic surgery. So we've come to the decision that we would not perform laparoscopic surgery at this time.
Okay, very good. Thank you very much. Next, I would like to call on Dr. Mariani in Italy. You guys have very experienced with COVID disease. You have a lot of patients. How does it affect what you do with your acute surgical patients? How did it change the treatment, or did it not? What do you do?
Okay, thank you for the question. I have to highlight a problem. We experimented that in this situation, we are in the middle of the cyclone few days ago, and we have experimented that sometimes we had leave the surgical patient untreated due to a COVID. This is a problem. We have to put our red flag very high, because in this week I saw a very dramatic surgical case about a simply appendicitis, simply cholecystitis, and so on. So the problem is that we have to don't leave surgical patient untreated due to a COVID. The COVID is a problem for sure, but we have to stay focused about the surgical problem. Don't forget that patient died to the problem related with the surgical situation. So it's difficult to give an advice, because it's a question of feeling. It's a gut feeling about the patient. You have to stay really close to your patient and try to understand what's happening inside him, and try to identify the right moment to the surgical therapy?
Yeah, I think it's a very good point.
Yeah.
Now we still don't have enough data to really say, you know, does the stress of surgery and general anesthesia, you know, how does it impact the disease progress of the COVID disease itself? You know, as we saw the one study from China for patients who had significant elective operations, they seem to do fairly poorly if they at the same time or shortly after surgery develop symptomatic COVID disease. Anybody else wants to make some comments before we close?
I think Dr. Hoyman from Boston needs to leave and he may want to have a comment.
Okay. Go ahead.
Or did he check out already? I think he's gone, Dr. Pust. Sorry about that.
All right.
Hey Dan, great presentation as usual. I think this format shows that there's still not a right answer. And they still don't know how they want to treat this in the future. The tests need to improve. Need to have the test should be faster, quicker answer. And we're gonna have this kind of case for a long time until have a vaccine. So I think our practice is going to be changed for the next year at least. And I hope everybody stays safe. And your lectures or your slides, your pictures are very informative. Congratulations.
I want to make Antonio.
Thank you, Marcos.
It's Ruben from Qatar. Okay.
Ruben,
I just want to congratulate the speaker and just to tell you that nowadays we consider all the patients highly suspected, meaning COVID positive until proven otherwise, and I think that's the best practice to follow.
I have a quick one and a question if there's still time.
Yes, go ahead, Alex.
Hi. So I think what we know, great comments from everybody, all the participants. I think what we know for sure is that definitely aerosolization puts at risk everybody. So for the patient with the abscess, definitely open surgery, and risk of aerosolization is less, and then definitely a wound vac. For the appendectomy patient, Dr. Kasim is right with the appendiculate, they have a higher chance of recurrence. But hopefully, if she did well initially with antibiotics, hopefully, if recurrence happens at some point where she can maybe get a laparoscopic surgery. I cannot recommend the open cholecystectomy right away unless somebody has emphysematous cholecystitis. There's been data in the past where patients can be cooled off with antibiotics and then had elective surgery done later. The only question I have is, I noticed the patient with appendectomy had the CT scan of the chest included with the abdomen, and the other one with intussusception was just the belly. So should we just scan everyone's chest if they get abdomen and pelvis? What do you suggest?
So that's a great question. So the patient with the appendicitis, they just happen to have the lower cuts of the lung as part of the abdomen. We just saw it in the lower cut, so it wasn't a dedicated chest CT scan. However, we did start to ask our colleagues in the emergency room, if patients come in who are sick of abdominal problems, to include a CT scan of the chest. So that's a good question also for the other participants in the audience. Should we routinely do CT scans of the chest when we scan the abdomen for an abdominal problem? Data have shown that the sensitivity to detect COVID on CAT scan is fairly high. Initially, our turnaround time to get a COVID test done was 2, 3, 4, 5 days. Now we do it in-house and we get it within the same day. But I think it's a good idea to consider to scan the chest, at least if you're in an institution where it still takes a few days to get the test results back. Any other comments or questions?
Would you like to tell us a little bit about that suction device that you're using?
So as you know, there is a Bobby which has a suction device attached to it, which can help you to suction the smoke if you use electrocautery in open surgery. We try not to use electrocautery at all if possible. Obviously it's not always possible in certain trauma patients and liver injuries and so on, but we have to be all aware of that you may have significant aerosolization of virus particle when you use electrocautery. for the laparoscopic surgery, for the filter device, you can put into the circuit when you basically deflate the abdomen and suction out the smoke. You know, it's highly effective to filter out the virus particle. The problem is, we all know when you do laparoscopic surgery, right? It's not uncommon that a trocar falls out, there's some air leaking out when the trocar comes out. When you put your laparoscopic instruments through the trocar, you often hear a little bit of air coming through the seal. And if you think about it, if the continuous airflow, the CO2 from the insufflator stops, we often lose our pneumoperitoneum, right? It goes down if the airflow stops, which tells us that we continuously have a leak, right? Most of the time. It's not just you put on one trocar, you put the filter on, and you filter the air coming out, and that's it, right? So the reality is, even if you use those devices, I think you're going to still have lose significant amount of air and potentially aerolizing virus into the environment. So I don't think we have good data yet to really show it, right? We have to prove it and measure it and see it, but we're still away from that. So, you know, but you can assume that you probably have a higher aerolization rate with laparoscopic surgery compared to an open operation.
So are you recommending that we don't try that for the time being?
Well, we currently not doing, or I don't want to say we, but I think most of us in Miami currently not doing a laparoscopic surgery. And it may change again. You know, again, the official statement from SAGES, if you look at the SAGES website, they say it's not contraindicated as long as you use the filtering devices and use full PPE and precautions. They do recommend to proceed with laparoscopic surgery. But I think a lot of us are hesitant about it, and a lot of us have colleagues, right, who did do surgery on COVID patients at the time when they didn't know that they had COVID early on in the disease process. Some colleagues of us in New York and so on, and they got severely ill. Everybody who was in that operating room. So there seems to be a correlation with the amount of virus exposure and the risk of how sick, if you get sick, and how sick you get. So yeah, so we're careful with laparoscopic surgery. We're very conservative with that. Let's put it that way. But I do have some colleagues who think we should do laparoscopic surgery and use the filter device, and that's it. But I think
I have one too.
Yeah. So I think nobody knows the answer for that yet. I think we need more data, and it's going to take some time.
Thank you.
Thank you. Okay, thanks to everybody. With that, we want to close, and I want to remind everybody that if I can share my screen one more time, in October, end of October, we have the Pan American Trauma Society Congress, and we all hope and pray that by that time the pandemic improved to a point that the numbers are so low that hopefully we're able to travel again, and then hopefully see you all well and sound in Mexico, in Merida, at the end of October through our Pan American Trauma Society Congress, which our president this year is Dr. Felipe Vega, hosting this Congress in Mexico. So hopefully, let's think positive and we'll be able to go to this Congress. Thank you so much to everybody.